Hello and welcome to this All India Ophthalmological Society education module on XEN, step by step. My name's Dr. Nathan Kerr, and these are my disclosures. In this module, we'll be looking at the pre-operative, intraoperative, and post-operative steps of successful ab interno XEN insertion. The XEN is a hydrophilic tube made of flexible porcine collagen, which has been cross-linked with glutaraldehyde to prevent degradation. It's the only minimally invasive subconjunctival surgery that can be inserted ab interno, and this gives it some unique advantages. It enables us to utilize the proven route of subconjunctival filtration, but in a procedure which is much less traumatic than conventional surgery. There's no need to perform open conjunctival dissection, similarly to suture, and no need to create a scleral flap or iridectomy. This results in a procedure which is shorter, which has a fast recovery for the patient, with a relatively low rate of complications and fewer post-operative visits compared to conventional surgery. The material is non-inflammatory and tissue conforming. The XEN's dimensions have been carefully selected to provide resistance to aqueous outflow to prevent against hypotony, which can lead to potentially serious and sight-threatening complications. There are various versions of the XEN, and for XEN 45, it's 6 millimeters in length with an internal diameter of 45 microns. It's indicated to reduce IOP in primary open-angle glaucoma, which is refractory to medical and/or surgical therapy. It can be performed as a standalone procedure or in combination with cataract surgery. The advantage of combined surgery is it gives us an opportunity to not only reduce intraocular pressure and medication burden, but simultaneously perform visual rehabilitation by removal of the cataract. This provides patients with a rapid recovery of vision while helping to reduce their intraocular pressures and number of glaucoma medications. Studies would show that combined surgery has similar efficacy to standalone XEN surgery. The XEN is contraindicated in angle closure except where the angle has been surgically opened, such as with cataract surgery. Similarly, it's contraindicated if there's prior surgery or scarring in the target quadrant, or if there's active inflammation or uveitis, including neovascular disease. If there's silicon oil or vitreous in the anterior chamber, this may occlude the XEN and the XEN should not be performed. And similarly, if there's impaired episcleral venous drainage or a history of dermatologic keloid formation, XEN is relatively contraindicated. One of the advantages of XEN is it leaves options for future procedures, like trabeculectomy and tube, should these be required. The goals of our surgery are to create a low diffuse bleb, which is posterior, comfortable, and efficacious. We can do this by applying the XEN expert principles, which were developed by Drs. Ahmed, Reitzheimer, and Stormans. These principles are designed to help provide predictable and consistent outcomes, effective IOP lowering, and to help shorten the surgical learning curve. There are 3 pillars: controlling inflammation, lowering conjunctival resistance, and minimizing bleeding. They can be remembered by the 4 Ps: preparation, placement, priming, and post-operative management. We're now going to look at a XEN surgery from start to finish, and then look at each of these principles in more detail. In this case, we're performing a XEN surgery on the patient's left eye, and they're pseudophakic. We're using a nasal speculum to provide access. We want to minimize conjunctival trauma. Here I'm using a squint hook to manipulate the eye. We want to minimize bleeding, and a topical vasoconstrictor such as topical phenylephrine 2.5% can be helpful. We now need to dry the conjunctiva before we use calipers to mark 3 millimeters from the limbus. We're inspecting the target quadrant, which is typically supranasal, ensuring that the conjunctiva in this zone is healthy and mobile. The next step is to hydroexpand tenon layer. We want to minimize bleeding by avoiding blood vessels and using a small 30 gauge needle can be helpful. There's various fluids that surgeons can use at this step. Some here use off-label antimetabolite. My preference is to use filtered air followed by a cohesive viscoelastic at this point to make a space into which the XEN can be inserted. If you are using antimetabolite here, you need to ensure that it does not pull at the limbus to help avoid the creation of an avascular bleb. Here, sweeping the fluid away from the limbus. And then washing with BSS to remove any antimetabolite from the corneal surface. We now make our corneal incisions, which are approximately 1.5 millimeters in diameter, about between 3 and 5 o'clock, making one to insert the XEN and a second for side port access. Acetylcholine can be helpful in phakic patients, but is not mandatory in pseudophakic patients. We now want to inject a cohesive viscoelastic. Some common brands include Provisc or Helon GV for this step. We now want to ensure that the XEN is perfectly placed. And our goal is to make a connection between the anterior chamber and, when inserting ab interno, I feel, the subconjunctival space. Some surgeons aim for a subtenons placement. Here we're inspecting the XEN, it's present, it's not damaged. And now rotating the speculum is important to give you access. Holding the globe with the second instrument and carefully inserting the injector across the anterior chamber, helping to avoid trauma with the iris or endothelium. We want to aim just anterior to Schlemm's canal, choosing a healthy area of conjunctiva, as close to 12 o'clock as possible. This can be performed as shown. Some surgeons prefer to do it under gonioscopic assistance. We want to exit the sclera no more than 3 millimeters from the limbus. Sometimes a little anterior can be helpful, so that ensures that we're anterior to tenon's insertion. We now want to increase the magnification, rotate the needle, and slowly advance the slider to deploy the XEN. And here we see the XEN deploying into the subconjunctival space. Once the slider is almost fully advanced, release your second instrument and control any forces so there's no lateral flick as the injector is withdrawn. Now inspecting the XEN, we want to ensure that it is freely mobile and straight, and we can adjust it quite easily at this step to ensure that there's 3 millimeters in the subconjunctival space, leaving 2 millimeters in the sclera and 1 millimeter in the anterior chamber, and this can be seen or visualized with a gonioscopic prism. We now want to prime the XEN to ensure that it's flowing and free before leaving theatre. Here I'm using bimanual IA to thoroughly remove all of the viscoelastic, being thorough but careful not to dislodge the XEN. This is important to help prevent an early postoperative IOP spike. Now leaving the irrigation port in the eye to increase intraocular pressure and to ensure that there is formation of a low and diffuse bleb on the table. Here we can see the low bleb starting to form. The XEN is nicely mobile and is straight. We really want to make sure that the XEN is not caught within tenons. If the XEN is curled in a pigtail type configuration, it should be needled at this point. As we'll discuss later, even if it appears free and mobile, there may be still some benefit of performing primary needling at the time of surgery, as shown here, passing a 30 gauge needle above and below the XEN in a sweeping motion. And this helps dissect that space, minimizing resistance in the subconjunctival space. And this, again, helps us achieve those outcomes without opening the conjunctiva. We're now going to look at each of these steps of the expert principles in more detail. First, preparation. It's important to ensure that the conjunctiva is healthy. We can do this by controlling ocular surface inflammation preoperatively. Ceasing glaucoma drops and using oral acetazolamide is helpful. Where time permits, a short course of topical steroids preoperatively can help minimize conjunctival inflammation. The next step is hydroexpansion, again expanding that tenon layer, and my preference for that step is filtered air and a viscoelastic. If using an antimetabolite, we must avoid pulling at the limbus, and we certainly want to avoid blood vessels to minimize bleeding. This diagram shows the placement of the XEN for a left eye. This mimics what we saw in the video, making the corneal incision between 3 and 5 o'clock. We want to try and inject as close as possible to 12 o'clock. If the incision is at 6 o'clock, it can be difficult to gain access because of the cheek. So 3 to 5 gives the greater access to the space. Here I'm performing the air XEN technique popularized by Dr. Ahmed. Again, having marked 3 millimeters from the limbus, I'm using a 30 gauge needle connected to a syringe with filtered air, injecting quite quickly and rapidly to dissect that plane, and then to maintain that space, injecting a cohesive viscoelastic. This nicely elevates the conjunctiva off the globe, giving a large space into which the XEN can be injected. The XEN is then performed, and then the antimetabolite is injected posteriorly behind the bleb. When placing the XEN, it's critical to avoid trauma to the iris or angle. We want to position the XEN as close to 12 o'clock as possible, and creating a connection where there's 3 millimeters in the subconjunctival space, 2 millimeters in the sclera, and 1 millimeter in the anterior chamber. We want to avoid going through Schlemm's canal, which could cause blood reflux into the anterior chamber and lead to postoperative hyphema. When withdrawing the injector, release all lateral forces to minimize any flick motions. Here is a diagram showing the XEN positioned correctly. Priming, we want to ensure that the XEN is flowing and free before leaving theatre. We do this by removing viscoelastic thoroughly, pressurizing the eye, ensuring that we see a visible bleb at the time of surgery, verifying that the implant is straight and needle, and certainly consider primary needling if the XEN does not appear to be free and mobile, because we don't want the XEN caught in tenons. Primary needling is performed at the time of theatre. A vasoconstrictor is applied preoperatively, and a 30 gauge needle is passed above and below the XEN in a sweeping motion. This helps dissect that subconjunctival space, separating and rupturing tissue adhesions. This helps ensure a low and diffuse bleb and minimizes subconjunctival resistance to help maximize IOP lowering. Here's another example of primary needling. We can see the air and the viscoelastic in that space. We're passing the needle above and below, really ensuring that it's completely free. We examined the effect of primary needling. We found that if you performed primary needling routinely at the time of surgery, even in cases where it appeared straight and mobile, there was a reduction in post-operative needling rates and number of clinic visits. Lastly, we're going to look at the post-operative management of XEN. Unfortunately, one of the major advantages of XEN is it has much less labor-intensive post-operative management for both the patient and the doctor compared to conventional filtration surgery. It's still essential to review your patients day 1 post-operatively, and we want to ensure that the intraocular pressure is ideally between 3 and 10 millimeters of mercury. Pressures less than 3 can be seen, often with no sequelae. But if the pressure is more than 10, we need to consider whether there's retained viscoelastic, or the XEN is occluded, perhaps by a strand of iris, or there's been insufficient hydroexpansion, or there's too much resistance in the subconjunctival space. We're now going to look at 3 scenarios after XEN: low pressure, high pressure, or XEN-related complications. Low pressure is commonly seen, in fact, is seldom a problem. Usually there's no clinical signs of hypotony, the anterior chamber is deep, there's no choroidal effusions, and this can simply be watched. There may sometimes be some signs of hypotony, such as a shallow anterior chamber or peripheral choroidal effusions. Again, in most instances, these can simply be observed, or sometimes a topical cycloplegic can be started. If there are later signs of hypotony, then tapering steroids can help cause a little bit of subconjunctival inflammation and fibrosis, causing the pressure to elevate. And if it really persists, which is rare but can sometimes be seen in cases such as high myopia or off-label use of uveitics, techniques such as compression and sutures can be used to limit the size of the bleb and help increase IOP. If the pressure is above target, we want to look at the bleb morphology to help us identify the cause and the appropriate management. If the pressure is high and the bleb is cystic, it's likely encapsulation. This can be treated initially with aqueous suppressants, which may lower the pressure within the bleb and lead to some remodeling. And if this is unsuccessful, then needling at the slit lamp or in theatre can be performed. If pressure is high and the bleb is diffuse, this is likely steroid response, which can certainly be seen after XEN surgery. The management is simply to taper the steroids more quickly and sometimes add in topical glaucoma medications if required. If the bleb is flat, it's likely due to fibrosis. We want to check internally that there's no occlusion of the XEN. And if there is no internal occlusion and the bleb is flat, it's most likely fibrosis in the subconjunctival space. If the XEN can still be easily seen, then needling can be attempted again in clinic, but often in theatre. If there is large amounts of fibrosis and the XEN cannot easily be visualized, then open revision is indicated. XEN erosion is a rare but potentially serious complication after surgery. If the XEN becomes eroded but there's no infective complications, it should be removed quickly. Topical betadine can be instilled in the eye, and often the XEN can be removed easily with forceps at the slit lamp before prescribing topical antibiotics. If there are already bleb-related infective complications, then these need to be managed as such, often with tap and inject, and removal of the XEN is recommended. So in summary, we've looked at the preoperative, intraoperative, and postoperative tips for successful ab interno XEN insertion. The key takeaways from this lecture are to look at patient selection carefully, to consider starting with combined cases, enabling you to simultaneously reduce intraocular pressure, medication burden, as well as providing visual rehabilitation. Preoperative optimization is important, and we want to aim for a perfectly positioned implant in every surgery. It's critical to confirm that the XEN is flowing and free before leaving theatre, and primary needling can be a useful adjunct at the time of surgery and may help reduce the need for postoperative needling and the number of clinic visits. Thanks for watching.